Awesome. Hey, my name's John Scott. I'm one of the dentists that was help evaluating all of the kiddos this week, and it's been really exciting. Thank all of y'all for coming. We've learned a whole lot from y'all, and I hope we've helped y'all a little bit along the way too. What we're doing today is just presenting a little bit of the dental findings that we have. And we'll start off talking about some of the findings we had during our exams, and then looking at all those secret x-rays we've been taking in the back rooms and kind of talking about those and some of the things that have come up with that. And then we'll talk about some possible recommended treatment considerations for some of these kids. So the big clinical findings we were talking about was a delayed time that the teeth were coming in, both as kids and some when they're about 6 and getting their permanent teeth in. Sometimes the baby teeth didn't seem to come in until 1 year old, 2 years old, about that time frame. We saw a lot of grinding in kids, which isn't uncommon. We see about 30 kids overall in our clinic that are doing some grinding, and we're helping them work through that. We did see a lot of excess saliva in some of the younger patients, which seemed to be resolving in some of the older ones around the 13 to 14 age range. Larger incisors, the front teeth was something that was very prominent in the population and kids. And we also saw some crowding. Another thing we saw was protruding incisors, just meaning that they would be hanging out below the lip line just a little bit. So let's talk about just a quick x-ray that I picked off the internet of a 6-year-old. And I just want to explain this one real quick. I got my mouse up there moving around. But this is an upper jaw here, and this is the lower jaw. This L stands for the left side, and this is the right side. This patient is 6 years old. His or her 6-year molars here. These are baby teeth, all in place here. And these are permanent teeth that are starting to form below the baby teeth. Here's a patient that's a little bit older, probably a teenager, maybe late high school, that we picked off the internet too. I just want to show you, this is a baby tooth that's still in place here. And these are the 6-year molars that are in place, 12-year molars. Like I said, upper jaw, lower jaw. So some of the radiographic findings that we had is it seemed like we had delayed or missing second premolars, mainly in the lower area. It seemed like about 80% of the kids were missing these. As far as the upper ones go, it was about 50% of the kids were missing those. We saw a little bit of delayed root development in the permanent teeth, mainly in the molar area. This was occurring around in like the 6 or 7 age range when we were getting x-rays on them. We saw some severely crowded, rotated, and erupting teeth. And then we saw a little bit of anterior tooth trauma and some taurodontism that we'll talk about here in just a second. So jumping through these x-rays, they're kind of a little blurry, getting a little movement with these, but this is a pretty good one. She was 6 years old. And we can see in this area, there should be one of the second premolars forming down here underneath this tooth. Same up here. The roots on these molars, as we talked about, is just a little bit shorter than what we'd expect in this age range. The other thing is you can see some of the teeth coming in are a little bit rotated. And we'll just look through a couple x-rays real quick and kind of talk about the implications of all this in a second. One of the big things we were asking about was with the unsteady balance. Did your child ever have any trauma to their front teeth? Did they ever have a tooth come out when they were little? And that was something we'd pick up every now and then on x-rays. Then another case where we have the delayed or missing second bicuspids. And then the delayed permanent root development in some of the molars far in the back. This is an 8-year-old, classic missing second bicuspids, short permanent roots, and this one has some severe crowding and also toroidontism. And what that all that means is that the crown of the tooth is a little bit longer. It's got a longer nerve inside of it, so if they're having any kind of dental treatment, the dentist just needs to be aware of that, and if they're taking x-rays, they will be, just to be careful not to expose that nerve during any kind of cavity preparation or anything like that. But that's something we picked up on. About 25% of the x-rays, they seem to have this phenomenon. Here's an 8-year-old. These are x-rays that we're taking in the operating room while they were asleep. We asked several of y'all about going to the hospitals and having treatment done, and this is one of the nice services about having that done, is they're able to take a full set of x-rays, do a big exam, and accomplish whatever they need to do that day. In her x-rays, we can see that we had those delayed or missing second bicuspids and the delayed permanent root formation in the molars. So when I talk about the delayed root formation, I don't mean it's not there forever. Last year we had one patient that was over the age of 18. He was 20. This year we had several that were over the age of 13 and able to take x-rays on them. And I don't have any of those x-rays in this PowerPoint just yet. But one of the nice things that we've been able to notice is that it doesn't look like there's a true lack of the roots forming down the road. It just looks like it's going to be a little bit later than expected. This is a 20-year-old. Now he's still missing the second premolars, but you can see he's maintained these baby teeth for quite some time. He's had them almost 17 years roughly. And his permanent teeth towards the back, we can see that they have developed some kind of roots. And that was kind of the trend that we saw with some 16-year-olds we saw this week, some 14-year-olds we saw. So I think that probably the molars come into place with a little bit of root that's developed, and then perhaps that root develops a few years down the road. Kind of the opposite of what we would expect, but it does look like eventually that does occur at some point. What would be ideal is to see a few more of those older kids and see if we can determine an age when that might happen. Does that happen at age 14? Does that happen at age 13? When is that actually occurring? What's significant about these radiographic findings for us as providers is hopefully when we have kids that are going to sleep, other special needs kids that have not been diagnosed, these are such diagnostic features and almost so rare in our dental world that I think that eventually dentists could be able to pinpoint, it looks like you're missing these particular teeth, it looks like these roots aren't developing on time, and they'd be able to provide an early diagnosis or lead up to a genetic referral so that these kids can get the necessary care that they need in other departments besides dental, which would be huge. Because this is one of the only syndromes that I'm aware of where we're seeing specific teeth like this missing. In Down syndrome and some of the other syndromes, we do see missing teeth, but unfortunately, it varies a lot. And we did see some variation in our kids this week. Some lower incisors missing in a few, but mainly these premolar teeth seem to be missing and those permanent molars. So if we can establish a protocol for dentists to be keeping their eye out for this and pass this on to other hospitals where they're having work done, then we can help identify these kids earlier and start getting them the help that they need. So with that being said, I'm going to let my buddy Dr. Adams come up here and talk to you a little bit about the treatment considerations for these patients, and then we'll take some questions at the end. Sorry, I should have turned it off.
Is it on? Bunch of amateurs, right? Thank you, Dr. Scott. I just wanted to come up here and speak too. That way I could, be cool and part of the group and everything. So I appreciate that. Obviously, I don't want to be too redundant with this today. You know, we spoke with each and every one of you about this, you know, and as it relates to really the age at which, you know, your child presented to us. And, you know, first off, I just want to say thank you all so much. You know, it was an honor to be able to be a part of this. You know, y'all are all such great parents, you know, and to take your time to come to Little Rock, Arkansas, and, you know, have us be a part of this is very meaningful. So we definitely, you know, want to say thank you for that. As far as, you know, treatment considerations, we spoke about bruxism, and you know, that's just a fancy word for grinding. Obviously, a lot of children, you know, not even just with SAPV2, experience bruxism. It's a very natural thing, especially as the permanent teeth are forming and erupting. That's to be expected. Just a quote there from the AAPD: bruxism typically stops once the 6-year molars have erupted. You know, in my experience, that even goes all the way up until when the 12-year molars erupt. Okay, so that's kind of a normal thing. And right here, I mean, I'll just read from the slide. If the child is still very young with baby teeth still present, nothing needs to be done, as we do not want to affect their growth, you know, as far as a bite plane, something like that. That's good for that. So, missing premolars, the second bicuspids Dr. Scott was mentioning. You know, what can we anticipate for treating this? You know, if the primary teeth, basically the way it happens is as the permanent tooth is erupting, it will resorb the roots of the baby tooth. That's why baby teeth get loose and they come out. So if that permanent teeth isn't erupting, it's not taking away those roots. So the roots is what's holding the tooth in. So therefore the tooth is going to stay in. Okay, so if those teeth are able to be maintained, and that's why we see them sometimes, you saw some on the panoramic x-rays up there a moment ago. If we're able to maintain them, you know, great, we don't need to put anything in that space to fill it. But what are some considerations if those baby teeth come out? Obviously, implants and bridges are not an option really until ages 18 to 20, because you want to have growth, you know, really, especially like in the, you know, female, you can do a little bit younger usually because they stop growing. But, you know, in men, really 20 to 21, you don't really want to start placing implants, because you'll put the implant in and the kid will continue growing, and then the implant doesn't fit where you originally placed it. So that's something to consider with that. But you have to be able to take really, really, really good care of the implant. You know, you have a crown on top of that, and implants are not 100% successful. If, you know, they can fail, and if you're not able to keep them clean. So that's something to really be aware of is compliance whenever you place an implant or a fixed partial denture. That would be like a bridge, you know, because you can get recurrent decay around those teeth. So that's something to be aware of. You wouldn't want to do anything without understanding that you could have compliance with cleaning those teeth. Orthodontic treatment. I know this is a huge question from many of the families. I'm not an orthodontist. We saw Dr. Simmons and Dr. Feather for the majority of those. But just, you know, a couple things to consider. We're talking about short roots on the molars. On many of those patients, as Dr. Scott mentioned, the roots seem to kind of continue developing just at a slower pace. But one thing to consider with braces is you're moving teeth. And if you move teeth too quickly, it actually blunts the roots. It makes them smaller. So that's a bad thing, because, you know, picture a large tree with a small root. It's going to tip over. Okay, that's one way to lose teeth. So whenever you're doing braces, you want to make sure you're going slowly. The orthodontist needs to be aware. I mean, they're going to be aware anyway whenever they take a pano and they see the roots. It's just a consideration that we need to be mindful of. Another thing that we recommended to many of the families over these past few days is seeing a craniofacial orthodontist. They're typically going to be on a craniofacial team. Okay, these are going to be hospital, university affiliated teams, and it's pretty similar to who you saw this past week. You know, you're going to have a craniofacial orthodontist, pediatric dentist, oral and maxillofacial surgeon. It's just a multidisciplinary team. And what is so good about this is that these specialists are equipped to handle patients with special needs and special considerations that a private practitioner is not typically, you know, going to be comfortable with. Additionally, as it was pointed out, say say I see a tooth that needs a filling on a kid that's not going to be cooperative in the dental clinic, and it's not worth going to sleep for because of the inherent risk of general anesthesia, so I'm just going to say, let's just watch this for now. Well, if there's something that the orthodontist would really love to do while the patient is asleep, or if there's something that the oral surgeon needs to do while they're asleep, or any of the other specialties, otolaryngology, putting tubes in, it's a great opportunity to have that whole collaborative effort of getting the patients in and getting as much done and utilizing that general anesthesia, appropriately. So that's another benefit from the craniofacial team. Here's a great example of some blunted roots. Like I said, occasionally seen after braces, especially if the braces were done too quickly, you're moving the teeth, it blunts the roots. So you can see, I'll take the little mouse right here. I mean, that's a very unfavorable crown to root ratio. Those teeth are just gonna wiggle out. So,
Hang on, go back.
oh.
Is it on? Oh. So my teeth, we're talking about short roots. My dad did my braces, he's an orthodontist, and my teeth look real similar to that. So just because teeth have really short roots does not mean they're not going to be there for a long time. I hope, at least. But yeah, it is one of the complications after braces, and I think those molars, once they develop roots down the road, even if they may be a little short, even if they'll be short now, I think it's going to be okay, because
Yep.
mine look pretty darn close to that, no matter how bad you were just bad now. Sorry.
How old are you? How old are you?
Great point. Yeah, it's a great point. I guess one thing to be mindful of is whenever you do have blunted roots like this, is hygiene needs to be even that much more meticulous. Because you've heard of periodontitis, that's basically attachment loss. So if you already have a shorter root, you just need to be that much more meticulous on it. That's essentially the point that I wanted to make. Trauma. Okay, so I feel like every room we went into today, it was the scenario, falling down, prominent front teeth, hitting them, high pain tolerance, often not even knowing that there was a trauma. They come back from school, there's a tooth gone. I mean, that was such a typical scenario that we saw with a lot of these patients. Obviously, each of you probably has already experienced this, so this is maybe a bit redundant, but in any event in dental trauma, it's definitely recommended to see a dentist. That way they can take an x-ray. I believe there was an event where there was a trauma and it looked like the tooth had completely come out, but there's still a root tip left in the mouth as well. So it's good to get x-rays, that way you can understand what's left. If a permanent tooth is knocked out, you can place the tooth in milk, believe it or not. Try not to touch the root surface. Just, pick it up from the crown, put it in a glass of milk, 2%, 1%, doesn't matter. Or there's also some over-the-counter products, and then you can just take it to a dentist, and then honestly, what they'll probably do is just rinse it with a little bit of saline, stick it back in, and then try to bond it together. If a baby tooth is knocked out, do not reimplant. Just seek dental care, make sure the whole thing's out. Usually we don't put those back in. All right, treatment facility options. Private practice dentists, pediatric dentists. Obviously you have laughing gas, which is nitrous oxide. That can be beneficial for some of our patients for treating them. Oral sedation or IV sedation are also possibilities. Hospital university settings, you get to utilize general anesthesia through that approach, which can be super helpful, as we mentioned before. Craniofacial or cleft team as well. A big thing though is all these kids need an individualized treatment plan. There are common findings among all of these patients, yet there's a huge spectrum as well. There are patients that had several teeth missing, there are ones that had no teeth missing. So you can't just have a blanket statement for treating these kids. These are just kind of findings that that kept popping up. And if for some reason you need to contact us, here is our names and email addresses. We're really good at getting back to y'all if y'all need that. So I'll leave, let me just go make sure it's it. Yeah, that's it. So I'll just leave this up here for a moment. Question, red shirt.
So I just in this quick time of reading, I got a chance to talk to some parents of older children last night, and it's obvious it's very expensive to get dental work done, especially in your specific field. And as I'm reading here, as defined by the American Association of Orthodontists, answer to the Affordable Care Act, there are auto qualifiers for treatment that's covered via insurance, and this seems to check off like 3 out of 4 of the boxes.
Mm-hmm.
What's your answer? Do you know what those auto qualifiers are? Are you familiar with those codes? What's the reality of that?
Yeah, so I've never been in private practice, nor do I really have experience with the financial aspects of things. So that question, unfortunately, is really not super. I'm not going to be able to give you anything that's going to be super helpful, unfortunately. As you mentioned, you said 3 of the 4 qualified. You know, I think it's worth just, you know, putting in a request and seeing what comes out the other end. You know, it's not super helpful. That's just obviously it's worth the shot. You know, and kind of like what we were saying with the craniofacial team. You know, there's nothing inherently a whole craniofacial issue with these kids, but how they present orthodontically and dentally necessitates a team like that. And you know, if these kids came through our craniofacial team, you know, we would have no problem seeing them in that way. So, you know, pursuing it that way might be a good option. And if I'm not sure if do you have anything to add to that? Yeah, unfortunately, this is the financial stuff. Honestly, it's one of my favorite parts about my job is I don't have to deal with that stuff. I just get to treat the patient the best of my abilities and kind of be done with it. Yeah, so great question. I hope maybe something can come of that soon.
Question for you as well. More
Yes, sir.
about just kind of preventative maintenance of brushing teeth. I think certainly our kid, maybe a lot of others, have a hard time spitting out toothpaste.
Absolutely.
And it's not very pleasant to swallow toothpaste.
Mm-hmm.
So some recommendations, you know, I've been told by doctors in the past, it's the brushing, not what you put on the brush. You can kind of expand on some of that stuff.
Yes, so Dr. Simmons, the orthodontist, I feel like he touched on this just about every patient that I was in the room with him. You know, his big thing is, you know, he's an orthodontist. He had 2 kids with braces. I think the story is, you know, whenever they're watching TV, you just hand them a toothbrush and they would just brush there, you know, just with a little bit of water, even just the saliva. That mechanical action of brushing itself is really the strongest benefit. You know, you can think about it. I think you mentioned kind of like waxing your car. You know, you're not gonna wax a car if it's got bugs and, you know, paint and, you know, a bunch of stuff on it, and you wax it. I mean, you're not really cleaning it. You clean it first, and then you put on the wax, or, you know, the toothpaste, as it were. So, you know, if they're not able to spit out the toothpaste, my advice is just to brush with water, and then at the very end, just put a very little bit of toothpaste on, and kind of brush throughout the mouth. Not enough to really create that kind of sudsy foaminess, but just enough to get fluoride on their teeth. And I would recommend doing that at night as opposed to the morning. You know, because in the morning you're going to do that, and then they're going to go and put something in their mouth, and it's just going to wash out. Whereas if you do it at night, there's a better chance of it kind of sticking, you know, staying in, soaking in. So that would be my recommendation with that. And obviously just, you know, I feel like some of these kids might tolerate just even holding on to a toothbrush and just kind of biting on it. I mean, that's huge. That's super helpful. You know, and luckily all the excess saliva, that's also very helpful with preventing cavities and cleaning the mouth. So that's a great problem. You know, if these kids were having xerostomia, you know, dry mouth, we would be in a completely different situation here. Yeah, great question. Yes, ma'am. Oh, just kidding.
You mentioned that if dentists knew some of the teeth abnormalities with our syndrome, it could possibly be an early sign or tip for them and lead them in the right direction to our group. One of the things that Allison is working on, one of the goals with the SATV2 Foundation is to create awareness of our syndrome. would it be possible for your team to maybe work with the foundation and create a cover letter that would go out with our information and our literature specifically on dental? Because right now it just says teeth abnormalities, and
Absolutely.
it sounds like there are enough specifics that maybe if that was sent with our information, and we have volunteers that I guess will be working on that, it may be read better and come across clearer than just saying teeth abnormalities.
Yeah, absolutely. Dr. Scott and I would be happy to kind of formulate a more. I mean, we've compiled this little lecture here today, and we can utilize all the information that we even gathered this past week to add additional things for that, and we'd be more than happy to do that. Just give us the information that we need to know how to contribute to that. Yeah.
That was actually my exact question, so.
Awesome. Yes, sir.
To that end, do you think you might have enough information compiled together to think about publishing, maybe in some sort of journal or something that dentists might actually read and get access to?
Absolutely. That's something that we're actually currently working on with Dr. Zarate. Additionally, it wasn't a publication, but John and I spoke in Seattle about SATB2. It was a conference, special patient care dental conference. And so these are our practitioners who, like John and myself, work in a hospital university setting, are treating special needs on a regular basis. And I feel like getting that information out to that group of dentists is imperative.
Yeah, that's where we actually receive dental care.
Go ahead.
That's actually where we receive our dental care is in Seattle.
Okay, awesome. Yeah.
Watch you.
Yeah, we've been really lucky because last year we came into this and we're trying to read some research articles ourselves, and all it said was teeth abnormalities. So we went into the exam rooms with y'all last year. We were completely blind and didn't really know what we were looking for. So it's really interesting to turn around this year and kind of we knew a little bit more about the patients. We were able to ask more direct questions. So yeah, that's exactly where we like to go. Start creating protocols, creating recommendations, putting some literature out there for awareness. So great questions.
And to piggy, I'm sorry? Yeah, while she's bringing the mic to you, just to go off of what Dr.
Folks,
Scott said.
If you have questions, if you can come up here, because this one is a little bit harder to drag around for the video camera.
You know, not only did we not know what we were getting into, teeth abnormalities, like how broad of a topic is that? It was also our first week of working here. We started on Monday, and I think Thursday it was like, hey, do this. So, welcome to the world.
So I had just a few questions regarding and this may be vain, but what about sealants for kids? I know what my daughter's potential teeth start to look like, and I'm terrified.
Right.
Is there any way to savor these baby teeth that haven't been so bad by putting sealants all over them?
Yeah, so the way sealants work, you're really just sealing the grooves of the teeth. Okay, that's where food and stuff is going to collect. So a couple things to note: if you don't place sealants appropriately and well, you have to have tremendous isolation because it cannot be wet. It has to be super dry. So you have to do it in a very controlled environment. If the tongue moves at all, you're going to put that on there. It's either going to come out or partially come out. If a part of it comes out and the rest of it stays in, food can get underneath it and actually make it worse than if they didn't have sealants. Okay, so first it needs to be understood that you have to do a really meticulous job with placing them. So it needs to be done, under care. That's one thing to keep in mind. But sure, yeah, I mean that's a great recommendation.
But
yeah.
It's not something isolated is not easy at all.
Right, exactly.
That's even an understatement.
And that's why if the kid is going to sleep for something, procedures and stuff, that might be something wise to mention. Say, hey, while you're in there, I think it would be very helpful, A, for you to assess if there's a permanent tooth down there, but B, to seal it.
So without looking like a really over-ambitious mother when we go to the dentist, that word trodontism?
Tordontism?
Yeah. I'm not going to try to say that to my dentist. He's going to laugh at me. But I know, based off a little bit of a dental exam that he did try to do with Ray, she has very bulbous, I think you all said, nerves, like a heavy. So she freaks out on the cleaning without me being like, you know, go easy on her and not looking like just a mom that's like, hey, take it easy on my kid. How can I actually like have medical data indicating she's not just squealing and crying because she's 5? It's reality that she's very, very sensitive to this. How can I?
You know, that's definitely a possibility. You know, with toroodontism, you have obviously the pulp is enlarged and there's a long trunk of the root, and so there's a lot of pulpal tissue. I'm not sure if that actually 100% correlates though with increased sensitivity. You know, increased sensitivity would come from lack of enamel or exposed dentin. Okay, so that is a possibility. I think probably, you know, some of that might even just be gingival stimulation. You know, if you're think about yourself, you know, getting flossed or something, that sort of sensitivity. I wouldn't overtly think that toroodontism would have a more sensitive tooth. You know, one of the considerations that Dr. Scott mentioned is that since the pulp tissue is bigger, if they needed to have a root canal or something, you might want to seek a specialist like an endodontist because it's a bit more complex to fill the root with the filling material, as well as if you're doing a cavity prep, you know, cleaning out a cavity, you might just want to take special consideration that you could hit the pulp maybe possibly sooner. I would not think that there would be increased sensitivity as far as like dental sensitivity, like the tooth itself.
Okay.
Yeah.
Thank you.
Great question.
You didn't mention flossing. Should we talk about flossing?
Let's not.
Okay.
No, I'm just joking. I'm just joking. Do you have a specific question about flossing though, for real?
I mean, recommendations. How often? My kid hates it, and she bleeds no matter how often.
Yeah. I mean, that's one of the things that it's going to be difficult, and you know, I really don't feel like I have a super helpful answer for that. You know, I think a floss pick would be more helpful than the string floss. You know, because I could see that, you know, being very, very challenging. But at the end of the day, if you're brushing the teeth really well, I think ultimately that's what's going to be the most helpful. I wouldn't stress too much about the flossing. Yeah. He said his dad's a dentist / orthodontist, and he didn't. How long? 20 years didn't floss. So. I feel like we shouldn't be saying this. This doesn't feel right, but yeah. Hopefully y'all see us next year. Anything else? All right.